So thank y'all for having me this morning. As you can tell, my expertise is not in hormonal management of menopause after GYN cancers. So this is a new talk for me, and you might find that I slip up and say something about the HPV vaccine because I love to talk about that. But I think when we talked about supportive care and what we needed to know to take care of women after treatment for any malignancy, actually, I do actually talk about things like melanoma in this. This was something that I needed to know more about in order to take better care of my patients. So that was why I offered to do this talk, because it's a great opportunity for me to learn, and I hope you can learn along with me. So we're going to talk a little bit about the background and treatment options for menopausal symptoms in general, and then go through GYN and breast cancers, and then hormones and other common cancers in women. So we know that there are 260,000 cases of breast cancer per year, and almost half of these are under 60. And then of the in situ cases, at least 50% of those are under the age of 60. And most are hormone receptor positive. So this means that women who may have been on hormones are now told that they immediately have to come off. Most of the treatment involves some combination or component of hormone blockade, and menopause can occur due to chemotherapy in addition to other things. And these women have a high survival. So, you know, that is great news, but I want you to think about how that just means that women have to live a long time with hot flashes. And for those of you who have experienced it or have a wife who has experienced it, it can be a really long process to get through. In terms of gynecologic cancers, we know there's 100,000 new cases of gynecologic cancer a year. 25% of these are uterine cancers that are premenopausal. So these are women who are now undergoing surgical menopause. There's an even larger number of women who are survivors of cervical cancer and may or may not have had a treatment that resulted in their menopause. And most of them are expected to live 10 plus years from their cancer treatment. So, you know, we talked a little bit yesterday about those papillary serous ovarian cancers, but there is that 15% of gynecologic cancers, the germ cell and stromal cell tumors, which are very survivable tumors, and women live for a long time, but may live with the impact of surgical menopause. So just to give you an idea, when we talk about surgery, this is a simple hysterectomy, does not require removal of the tubes and ovaries, and technically some of this lingo is wrong. Obviously you can remove one and leave one, you can just do this. And when we think about a radical hysterectomy, we think about removal of the tissue on either side of the cervix, which actually can impact both bladder and rectal continence as well as sensation. Another joy of the surgeries that we perform. And sometimes we do remove the tubes and ovaries, and sometimes we keep them. So it's important to establish with the patient what was removed and what is still there, and what symptoms they might be expected to find. I will say for cervical cancer, sometimes we remove the uterus and cervix as well as the parametrial tissue, leave the ovaries in place, but on the off chance that they will have radiation, we PEX the ovaries up out of the radiation field. So once they're detached from the uterus, they're pretty mobile. Their blood supply comes from the aorta, so we actually move them up over the iliac crest and suture them down so they're out of the way. Now this procedure alone is associated with a risk of menopause because of the change in blood supply to the ovaries. That being said, there are some women who can have a hysterectomy and pelvic radiation and not be menopausal. So it's really important to establish what they had done and where they are in their course. So when we think about treatments that cause menopause, we know hormone blockade does. Chemotherapy in a woman who's perimenopausal can often result in premature ovarian failure. Oophorectomy is obviously surgical menopause, and radiation. You only need 25 gray to the ovaries to cause menopause, and the average dose of whole pelvis radiation is 45 gray. The average dose of a curative intent cervical cancer treatment is 80 to 90 gray. So definitely does cause menopause if those ovaries are in the radiation field. So we know the menopausal symptoms, the systemic symptoms: hot flashes, night sweats, sleep disturbances, mood changes, irritability, and memory impairment. We know the localized symptoms, the urogenital changes, vaginal dryness, dyspareunia, ultimately resulting in sexual dysfunction. Both of these can lead to a very high risk for depression. You know, I don't have to spend a lot of time telling you that menopause causes increases in hospital and ER utilization and cost, but we know that depression does. We know that all of this can result in depression for women, largely due, and it's a chicken or the egg phenomenon. They have sleep disturbances that cause memory impairment, etc. And then we go on to have depression, which causes sleep disturbance. And so you really kind of don't know if it's the chicken or the egg. You really do have to treat the multitude of symptoms, especially if you're not treating the hot flashes themselves. So it's important to really address what symptoms are the most prominent. You know, not every woman experiences all of these things at the same time, but it's important to address them and see what you can treat. So I threw a few menopausal jokes in here. This one says, when a menopausal woman says what, it's not because she didn't hear you, she's giving you a chance to change what you said. So the treatment of menopausal symptoms, standard things, hormones, come in all different types and varieties. There's pills, patches, pellets. They have estrogen, progesterone, and testosterone. A moment about that, I want both you to understand and your patients to understand that pills and patches are FDA approved and FDA monitored. Pellets are not. And it's important for patients to understand that the doses that are in pellets are unknown. And there is no standard FDA-approved saliva hormone monitoring test. There is no FDA-approved pellet product for testosterone for women in particular. There is one pill that contains testosterone and one patch that contains testosterone, but women using creams for estrogen, well, I don't believe there is an estrogen cream, but a cream for progesterone or testosterone, or pellets that contain those products really have an unknown impact on women. And unfortunately, I have seen, and I suspect some of the medical oncologists in the room could say that they have seen women who have had cancers related to this pellet use. It's something that it's still, in my mind, considered very controversial. And for any woman who has a hormone-sensitive cancer, the first thing we do is get the pellets out, obviously. There's a localized therapy, estrogen creams, pills, vaginal rings. Estrogen creams are usually used intravaginally. There are also progesterone creams and things like that. I had one endocrine doctor tell me that, you know, progesterone cream is largely a placebo effect, that a woman could take a bath in progesterone cream and it would not be enough to combat some of the higher doses of estrogen that they are given in the pellet form. The SERMs, the selective estrogen receptor modulators, such as Osphena, and then the laser therapy, we'll talk a little bit about that, and then the alternative therapy, so herb supplements, acupuncture, exercise. There's a lot of different options for women, and I think it's important that the women know there are options other than hormones, and yet what the standard treatment is, if a woman has moderate to severe hot flashes and does not have a hormonally sensitive cancer, the standard treatment is a hormone. And that has to be okay. We can't take every woman off of the hormonal management if their cancer is in fact not responsive to hormones. So I think it's an important distinction that, you know, not every woman has to come off of their hormonal therapy just because they were diagnosed with a cancer. It's really important to look at what the cancer is, and we'll talk a little bit about that. In fact, in a lot of these studies, hormones were protective for survival. So I think it's an interesting question and one that I can't really answer, but as a resident, back when I did benign gynecology, we would get calls all the time that a woman with acute an AML or an ALL who had acute leukemia admitted to the hospital, and the first thing they did was took her off her hormones. And then she bled, and they called us because she bled. It's called a hormone withdrawal bleed. It's a period. They called us for a period. So I think it's, you know, making sure that there's a gynecologist or the patient's gynecologist involved in those decisions so that not every woman is immediately taken off. So this is a list of the products for estrogen replacement that are FDA approved. This is an incomplete list because this is only the pills. Well, I guess there are some creams on here too. The point is, it's a very diverse list, and there's a lot of options that need to be discussed. And often, this is a decision that you want. Once you've decided that it's safe for a woman to be on hormonal therapy or not, then a recommendation can be made to their OBGYN, and then the type of therapy that is given is more appropriately counseled and given by an OBGYN. because there are a lot of different options. So briefly, the Women's Health Initiative, I think it's important to know what this study did and did not say. The first thing is that when we look at estrogen plus progesterone compared to placebo, there are risks, benefits, and things that really didn't change. So there was a slightly higher risk for heart attacks and strokes and breast cancer and blood clots. Not a surprise, but it is interesting to note that those risks were higher with combination therapy than they were with estrogen only. Now, the benefits. This is the first place that we saw a potential benefit of colorectal cancer protection and an obvious protection against hip fractures. And interestingly, endometrial cancer, because it was combination, was neutral, and deaths was neutral. So I think it's important to know that just because a woman had an increased risk for breast cancer or heart attack, it didn't ultimately result in a mortality problem. So I think when women are trying to decide whether or not to go on hormones, the most important thing to remember is it's not the fountain of youth. It's not going to prevent heart attacks. It's not going to prevent strokes. It's not going to be the thing that keeps your skin from aging. But it is something that can be used for a short period of time to treat hot flashes. And I think that's where the counseling really has gone, is that there are long-term risks. The other thing to keep in mind with the Women's Health Initiative is these were women who initiated hormones at ages 60 to 70, and I think we all agree that we really don't think women in their 60s and 70s should start on new hormones because of their risk for heart attack and stroke at baseline. And it's a very different thing to talk about a woman who's 40 to 50 and whether or not they can be on hormones for a short period of time to treat their symptoms. So there are other treatments. We know that antidepressants and anticonvulsants are the most commonly used treatments. The low-dose paroxetine or Paxil is the only FDA-approved SSRI for hot flashes, although women will tell you they've noticed a reduction in hot flashes associated with whatever was the SSRI that their doctor started them on for the depression that occurs simultaneously with some of these menopausal symptoms. And there are proven effects for randomized control trials at 12 and 24 weeks of therapy. Venlafaxine is the 75 milligram ER is what was studied most closely, but obviously the extended release does have some difficulty getting approved by insurance, and so 75 milligrams BID up to 150 milligrams BID was equivalent to low-dose estrogen, which I really liked, and better than placebo for reducing hot flashes. And this is the most commonly prescribed drug for breast cancer patients who are not candidates for hormonal therapy. Gabapentin is more effective than placebo, and for patients who have maybe a concurrent pain syndrome or something like that, this can be a really nice drug. It doesn't have to be the high doses that we associated with pain management, but 300 milligrams TID up to 400 milligrams TID is an appropriate dose. And then clonidine has some efficacy, but experts have really moved away from clonidine as a treatment for hot flashes because there are other equally to slightly more effective drugs and don't have the same side effect profile as the clonidine with the malignant hypertension associated with coming off of it. So this is a doctor talking to a patient about her menopausal symptoms. Says, you need a really strong medicine to relieve your symptoms. I'm prescribing chocolate. So lastly, we have all the things that are not medicines to look at, and I think this is really interesting. When you actually look at the trials and data, there's not a lot of good data out there. 11 randomized trials of soys or phytoestrogens, only 3 showed a benefit, and a meta-analysis of 43 trials showed no benefit, with the exception of genistein, which I've never heard of, or possibly above 30 milligrams a day. Black cohosh had short-term studies showed a benefit, but it was not borne out in meta-analyses. And there are some hepatotoxicity concerns for patients who are on it for a long period of time. So I think it's something to consider. Obviously, there is some placebo effect with that. I think the important thing is, other than these safety, the hepatotoxicity, safety concern for long-term use, these are considered safe. There are some patients of mine who have told me they have experienced a benefit from Estravent, which is an over-the-counter, not FDA-approved product that contains both soy and black cohosh. I would say it's about a 30% reduction in hot flashes, aka equal to placebo effect. But placebo effect is very powerful. So Lastly, behavior changes, wearing layered clothing, make sure your ambient temperature is cold despite your husband's protests, using a lot of fans, avoiding things that make you feel hot like alcohol and spicy foods. And then there is some data, although very limited, on acupuncture, meditation, exercise, yoga, cognitive behavior therapy, and hypnosis. Of those, hypnosis is the most powerful, with a 73% reduction in your hot flashes after a hypnosis session, although I don't know of any hypnotists that I would refer my patients to. So I would say it's of limited reach. So next, I think important to address the genitourinary symptoms separately from the systemic symptoms. And there are some over-the-counter silicone-based lubricants that can help with the dyspareunia specifically. I know Tamika's going to spend a lot of time talking about sexual dysfunction in patients, so I won't spend too much time here, but simply to say that dyspareunia is, unfortunately, it's a downward spiral. So the more painful intercourse a woman has, the more painful it will be. There are both normal muscular contractions and then the subconscious muscular contractions that are associated with a fear or anticipation of painful intercourse. And so it's something that kind of gets worse and worse and worse. And so it really is important to treat at the outset. And then if the patient really is kind of down that spiral road, they're going to need pelvic physical therapy to learn how to relax those muscles and treat some of the cramping that comes with the constant painful intercourse. So some of the things that have been used, vaginal estrogen was similar to Replens, and Replens is an over-the-counter product. Is Replens over-the-counter or is it prescription? I think it's over the counter. Yeah. Okay. And then for moderate to severe symptoms, it's important to remember that low-dose vaginal estrogen has very few contraindications as long as it is a dose below what would be considered systemically absorbed. So a meta-analysis of 50 studies proved that it was better for relief of genitourinary symptoms than even systemic estrogens. So if a woman comes to you and their only symptoms are genitourinary, it's okay to start them on a vaginal product, and it's going to work better than a pill form. There are some patients who would even qualify for combination therapy, although not our patients who have a hormonally sensitive cancer. And then only one prospective study in cancer patients, 69 breast cancer patients followed for 12 months with no increased risk for recurrence. Some of these products, the Vagifem tablet in particular is a 10 microgram tablet. It's such an incredibly low dose. It really does a nice job of treating the vaginal tissues without any systemic absorption. So next, there are newer modalities. The vaginal progesterone is an FDA-approved product for dyspareunia. It works by aromatization of the more androgens, and then it does qualify as a hormonal therapy. And then the ospemifene or SERM, a selective estrogen receptor modulator that was approved by the FDA for moderate to severe dyspareunia. It is an oral tablet that is taken, and it can actually, because it's a selective estrogen receptor modifier, it actually increases the risk for hot flashes, so that's not great. But the endometrial safety and breast safety in non-cancer patients is well established. The safety in cancer patients is not. And so ospemifene is still something that is said to be used with caution in a cancer patient, even though it is supposed to be selective for the genitourinary tissues. So Tamika might be talking about this a little bit, but there are non-hormonal methods of increasing vaginal lubrication, such as the Mona Lisa Touch. This is a laser procedure done in the office with no anesthesia required. It's a CO2 laser that does micro cuts or burns to the surface of the genitourinary skin and actually increases both the keratinized skin and the lubrication for women even after radiation. There are very few randomized trials with this because obviously you would know if you'd had it or not, but it does appear to result in thickening of the skin, and a lot of patients state a benefit, but very limited data in terms of randomized trials. So I think that I'll leave you with it's important to ask about women's sexual function, and we'll get into that a little bit later, and it's important to offer treatments even for patients who cannot take systemic hormones. So HRT and gynecologic cancers, first we'll talk about ovarian cancer, that being the obvious one that most women undergo hysterectomy with removal of the ovaries. There is good data about conservative surgery in younger women, with non-epithelial ovarian cancers, but when we think about this, most of the women with stromal malignancies actually do have hormone receptor positive cancers, and a hysterectomy with removal of both ovaries is the mainstay as long as they've completed their childbearing. And for women with germ cell malignancies, they're more likely to undergo fertility-sparing surgery, but they're also more likely to be under 30. And when we look at a prospective cohort of women with ovarian cancer and those cancers of low malignant potential, 26% reported hormone use prior to diagnosis, and the use of hormonal therapy was associated with improved survival, not decreased. I think that's important. And then second, a randomized trial that included both pre- and postmenopausal women. Again, survival was significantly improved with hormone replacement therapy. Now these women would have all gotten estrogen only because they would have had their uteruses removed. And a relapse-free survival was actually better in the hormone replacement group. So these are all statistically significant improvements in survival for actually giving a woman hormonal therapy. These are not the stromal malignancies. That's important to point out. That these are not the women who actually had a known ER-positive receptor on their tumors, but this is a group of the epithelial cancers, and in women in particular that undergo surgery that results in surgical menopause. They can have a significant amount of symptoms. And then a meta-analysis that was 1,000 women total, overall 50% improvement in survival and no difference in recurrence. So I think there's a lot of questions raised by this data, but I think the main takeaway, without any of us diving further into what the receptors look like on the surface of the cancers and things like that, the takeaway is certainly it's safe. I wouldn't say that every ovarian cancer patient needs hormones to improve their survival, but I would say absolutely if a woman has moderate to severe systemic symptoms, that low dose oral estrogen is perfectly safe. So HRT and endometrial cancer. So 25% of these patients diagnosed premenopausally. Endometrial cancer is 80 to 90% of the time considered a cancer of hormone imbalance. And stage 1 does have very high cure rates, which results in a long survival. And again, that proposition that a patient's going to live for a long time with their menopausal symptoms. But most cancers are low-grade estrogen receptor positive, and I think for gynecologic oncologists, this is the place where we really have a lot of trouble. Women were on hormones or ultimately had surgical menopause and now are feeling a lot of symptoms. We know that combination therapy is protective, but after hysterectomy, almost always we recommend that they come off of their hormonal therapy. So this is my favorite for Alabama. Couldn't you just say she's having hot flashes instead of she's packing heat? So this was a randomized control trial of 1,240 patients, oral estrogen versus placebo in low risk endometrial cancer, lowest for recurrence, that is. Patients had 3 years of therapy and 2 years of follow-up, and the recurrence was the same in both groups, not statistically significant. The rates of new breast cancers, interestingly enough, were similar between the two groups also. It's important for endometrial cancer patients to know that many of the risk factors for their endometrial cancer, like weight, are the same risk factors for breast cancer. And so just because they were on hormones does not necessarily mean that that was the reason that they got a new breast cancer. It may in fact be a weight-related risk. So there was a case control study of patients with a little bit higher risk endometrial cancer. 130 received hormones, so about half received hormones, and of those, half received combination therapy. And they were matched, and they had 2 recurrences in the HRT group and 11 recurrences in the untreated group. So it does leave some questions about the protective nature of hormones in endometrial cancer recurrence. But I think, again, the point is for low dose hormones, it is not unsafe, although it certainly should to be used with caution. I think for some patients, if we're going to do it, we often do combination therapy because of the concerns about estrogen only in an estrogen-sensitive cancer. Lastly, this is a meta-analysis of, again, the 1 randomized control trial and 5 observational studies. And we have, once again, a 2.1% recurrence in the hormone group versus a 6% recurrence in the non-hormone group, or an overall survival risk of 0.53, so a hazard ratio that was improved. So no reason to believe that hormones increase the risk of recurrence. So uterine sarcomas are a different entity. Uterine sarcomas actually are hormonally sensitive. They are hormonally active, and there is controversy about whether or not to leave a young woman's ovaries in place. I will say that it depends on the patient, but unopposed estrogen in particular is not recommended in these estrogen sensitive sarcomas. So if you end up in a situation where you're concerned about surgical menopause or the patient is particularly young, we consider it safer to leave the ovaries than to give them HRT. So I think, again, removal of the ovary should be individualized to the patient's risk, but ultimately these are patients who will have surgical menopause and will need some sort of alternative therapy. Cervical cancer, again, the rate of ovarian metastasis in squamous cell, which is 85% of cervical cancer, is low. But if they have a high-grade adenocarcinoma, the ovaries are recommended to be removed. Obviously, for the patients treated with radiation, most will undergo radiation-related menopause. And the tumors are not hormonally active, and actually this is the one place where I can say HRT is preferred, particularly for women undergoing radiation therapy, because it is protective against things like hip fracture, which they're at increased risk for after pelvic radiation, as well as the sexual dysfunction associated with radiation to the vagina. So they actually do better and have a higher overall survival if they are on HRT. So this is the one place where I say if you have a young woman with cervical cancer, make sure she does get on HRT. Sometimes I do wait till the completion of therapy so that we don't have an increased risk for blood clots, but these are patients who need to go on therapy. Keep in mind, if a woman had radiation for her cervical cancer, her uterus is still in place, meaning she needs combination therapy, not estrogen-only therapy. So HRT and breast cancer, this is a short part of the talk because unfortunately most are still not recommended. So most patients experience some form of systemic symptoms for treatment. Up to 30% can be severe for all the reasons we talked about before. And these can be localized symptoms, decreased libido, arousal, dyspareunia, anorgasmia, and body image concerns. And unfortunately, 3 RCTs evaluating post-therapy HRT. The 2 biggest were closed early due to increased risk for recurrence. So up to a 2-fold increased risk for recurrence associated with the use of HRT after treatment for breast cancer, and the long and short of it is not recommended. There was not a difference in overall survival. So when we look at the other common cancers, lung cancer, interestingly enough, lung cancers have ER receptors. And there is an association of increased proliferation in the lab with estrogen exposure. That being said, a meta-analysis of 14 studies showed no association between the use of HRT and the development of lung cancer. And HRT use in survivors is inconsistent, but keep in mind that nobody recommends HRT to a smoker, particularly one who's old enough to have developed lung cancer. So this is largely a group that we would be taking off of their hormonal therapy, but if it is a young woman going through menopause after treatment for a lung cancer was not related to smoking, certainly that is a patient who could go on HRT without any concerns. Colorectal cancer. So actually colorectal cancer is one of the others that HRT shows a benefit. We know that estrogen appears to have a protective effect on the development of colorectal cancer, and a meta-analysis of 4 randomized controlled trials showed an inverse relationship between HRT use and colorectal cancer development. So that means that if you used it, you didn't get cancer. Slattery et al. Showed an improved 5-year survival for colorectal patients who were on HRT. And so it's one of those things, again, I'm not saying go out and start every colorectal cancer patient on hormones, but it is something that if they have moderate to severe symptoms related to menopause, certainly it's safe, and that estrogen should be considered. And again, these are women who may or may not have a uterus still in place, and you need to take into account the need for combination therapy. And hematologic malignancies, interestingly, the existing literature shows no consistent link between HRT and hematologic cancers, and there's supposedly a decreased risk of non-Hodgkin's lymphoma for HRT users. But most importantly, HRT after cancer, we know that women have a very high risk of ovarian failure after stem cell transplant, and HRT is highly recommended in these young women with premature ovarian failure, and does not appear to be associated with any increased risk for recurrence. And again, the last thing that I added was to avoid hormone withdrawal in the active phase of treatment. If a patient has platelets of 7,000, you do not want them having a period, aka keep them on their hormones or transition them to Lupron or in some other way support them through that phase without a hormone withdrawal bleed. Melanoma and HRT. So we know that actually women have dark patches in pregnancy. So the linea nigra gets darker. You can have darkening of the areola. You can have dark patches on the face or melasma, the mask of pregnancy. So you have to wonder, does all this estrogen increase the risk for melanoma? But observational studies show no association between HRT use and the risk for melanoma, and a single cohort study again showed improved survival for melanoma patients on HRT compared to those who were not. There is no randomized controlled data. So to replace or not to replace, we are going to replace hormones in women who are having symptoms for colorectal cancer, localized melanoma, cervical, vulvar, vaginal, and to consider in low stage, low risk endometrial and ovarian cancers in young women. We are not going to replace the hormones in women with breast cancer, high grade, high stage endometrial cancer, uterine sarcomas, granulosa cell tumors, those ovarian cancers that do have ERPR receptors on them, and the endometrioid adenocarcinoma of the ovary, which is again a rare histologic entity which has estrogen and progesterone receptors. So this is lastly menopause. So what you're saying is that what I have to look forward to is 10 years of hell followed by death. So when we arrive at menopause, who was it? It was Scalisi yesterday said you can either like gradually arrive at menopause, taking an exit off of the hormone pathway, or you can crash into menopause with surgical menopause. And I think that ultimately these are the things that we need to take into consideration when we're recommending a treatment for women. So lastly, for moderate to severe symptoms, HRT should be considered if it's not contraindicated for that particular cancer. And if it's contraindicated, there are lots of non-hormonal alternatives that are preferred. And lastly, that genitourinary symptoms are common, that it can be devastating to patients and couples. I've had couples break up over their inability to have intercourse, and needs to be both asked about and managed, and low-dose localized vaginal estrogen preparations are an option even if oral HRT is contraindicated, and there are alternatives to HRT, but limited long-term data. Local vaginal preparations of estrogen, the one I prefer is Vagifem, which is a tablet. It's a 10 microgram tablet, because then you do not have this problem of them putting however much they want to up in there.
Also the estrogen maybe?
So I think the estrogen is another one. I apologize that I do not know the exact daily release of the estrogen, but it is also considered a low dose product. Of the two, my understanding is the estrogen is associated with more systemic symptoms than Vagifem. And the trouble with the estrogen is that it is a 3-month dose that you're putting in, as opposed to the Vagifem where you can monitor for systemic symptoms and cut back. So you can, start at 3 times a week for very severe disease, 2 times a week is the standard dose, and then cut back to once a week if the patient experiences any systemic symptoms with that. So I have to say that's my personal preference, and it would depend a little bit on what type of breast cancer the patient had before I would consider an estrogen. That's a great question, and there is some data developing in BRCA patients that there does not appear to be an increased risk for familial cancers after they have had appropriate surgery, right? So we're talking about women who've already undergone mastectomy and oophorectomy for prevention of cancer. Those women would be considered safe for hormone replacement therapy. They've had their risk reduction down to what is considered the standard for patients, and particularly women who undergo surgical menopause at age 40, there probably is a benefit, although the trials aren't long enough to see that. That being said, for women who are choosing screening over surgery, they don't need hormone replacement therapy until they go through menopause because their ovaries are still there. And obviously as a gynecologist, we don't recommend screening to anyone. And then there's the rather unusual case of a woman who has chosen to have a hysterectomy and ovarian removal but not have a double mastectomy. I think that falls into a really interesting group of patients. Many of them may even be on some sort of oral prevention mechanism like a tamoxifen or a raloxifene, in which case obviously HRT would be contraindicated. And so I think that that group of women who had their ovaries removed but not a double mastectomy, I think it would be a very individualized decision that would depend on the severity of their symptoms, and you probably try a non-hormonal method. If they broke through that, then I think hormones for a short period of time, you know, under the age of 50 is not inappropriate. Other questions? Okay, thank y'all so much.